Chapter 3. The Evidence Gap. Why spinal fusion is not proven. Spinal fusion has been the most common surgical treatment for adolescent idiopathic scoliosis, AIS, since the 1960s. Yet many families do not realize that this operation rose to the top without the kind of long-term, high-quality proof we expect for other major medical choices. In this chapter, we will unpack two landmark reviews that pulled back the curtain on what is really known and not known about fusion. Together, they show a clear truth. The research record is full of holes, the risks are underreported, and surgery has never been proven better than careful, non-surgical care. Knowing these facts helps parents, teens, and even doctors weigh options with open eyes instead of old habits. How big studies work and why they matter. Before we dive into the numbers, let's pause for a quick lesson on study design. Medical researchers grade evidence kind of like teachers grade homework. Prospective, controlled trials, where two groups start at the same point, are treated differently, and are tracked over time, earn the highest marks. Retrospective series, where doctors look back at patient charts after treatment is done, earn lower marks because memories fade, data get lost, and there is no real control group. Case reports and expert opinion sit at the very bottom. They can point to ideas worth testing, but they cannot prove cause and effect. When we ask, does fusion lead to a better life than living with the curve? Only top-tier studies can give a solid answer. Anything less leaves room for bias, wishful thinking, or plain old human error. Now, let's see what the best reviews found when they hunted for that top-tier proof. The Westrick Ward Review, a search that came up empty. In 2011, orthopedic researchers Dr. Robert Westrick and Dr. William Ward set out to settle a pressing question. Does spinal fusion beat natural history over the long haul? They gathered every English language paper they could find on fusion in AIS, covering 5 to 20-year follow-ups. After sorting and screening, they kept 39 patient groups large enough to matter. Then, they looked for at least one well-designed, prospective, controlled study that compared fused teens with similar teens who skipped surgery. They found none. Let that sink in. More than half a century after the first Harrington rod was placed, there was not a single gold standard trial proving that fusing the spine helped kids live longer, feel better, or function better than those who stayed natural. The authors wrote a line that still echoes through scoliosis research circles. There is no medical necessity for surgery based on the current body of literature. In simpler words, the need for fusion has never been proven by today's strict scientific rules. Of course, that does not mean fusion never helps. It means we do not have the strong evidence normally required before calling it the best or only choice. What the missing evidence means day to day. Imagine two roads. One is paved, tested, and mapped. The other is a shortcut people swear by, but no one has ever walked all the way to the end to see where it really goes. Which road feels safer? Fusion, according to Westrick and Ward, is still the second road. Over decades, thousands of teens have taken it, and many have reached adulthood in good shape. Yet until a true prospective study compares them to teens on the non-surgical road, we cannot say the shortcut is actually faster, safer, or wiser. Why hasn't such a study been done? There are several barriers. Ethical concerns. Some surgeons worry it is unfair to withhold fusion from teens with large curves, even though we now know many big curves live peaceful lives. Cost and time. Tracking hundreds of patients for decades is expensive and slow. Changing technology. Screws, rods, and surgical skills evolve, making it hard to compare today's surgeries with those done 20 years ago. Yet none of these hurdles change the bottom line. Proof is missing. The Weiss and Goodall Review, complications that range from 0 to 89%. If Westrick and Ward asked, "Where is the proof of benefit?" Dr. Hans Rudolf Weiss and Dr. David Goodall asked, "How often do things go wrong?" Their 2008 systematic review covered fusion complications in scoliosis from dozens of studies. The answer they found was eye-opening. Reported complication rates ranged from 0% to 89%. Such a wide range tells us two things. Complications definitely happen. An upper limit of 89% cannot be ignored. Reporting is wildly uneven. Some studies list every minor event. Others mention only major problems or stop tracking after a year or two. Weiss and Goodall warned that long-term harms, like hardware breakage, infection years later, or faster wear in nearby spinal joints, are often underreported. They worried these hidden costs could actually outweigh the everyday limits of living with an unfused curve. Common fusion risks in plain language. Below is a list of possible complications, translated into 8th grade English. Infection. Germs get into the wound or around the metal and can cause fever, pain, or the need for more surgery. Hardware failure. Rods or screws can bend, break, or move. Fixing them may require another operation. Pseudoarthrosis. The bones do not fuse solid, leaving a false joint that hurts or weakens the spine. Nerve damage. Rare but serious. Tingling, numbness, or even weakness can appear if a nerve is stretched or pinched. Blood loss. Fusion can mean long hours in the operating room and significant bleeding. Adjacent segment disease. Joints above and below the fused area carry extra stress and can wear out faster, causing pain years later. Stiffness and activity limits. A fused spine does not bend the same way, which can affect sports, dance, or simple tasks like tying shoes. Psychological stress. Worrying about fragile hardware, scars, or body image can lead to anxiety or low mood. Each risk alone may be small, but together they create a picture that every family should see before signing a consent form. Weighing risks against natural history. In the previous chapter, we reviewed a 50-year study showing that most adults who skipped surgery led normal lives. Only about 1 in 5 felt short of breath, and many of those had curves above 80 degrees in the chest. Now place that finding next to Weiss and Goodall's wide complication range. Ask yourself, if a teen has a 40, 50, or even 60-degree curve with no pain or breathing trouble, is it wise to risk infections, repeat surgeries, and lifelong stiffness for an unproven benefit? This question does not say fusion is never correct. Some curves do keep growing. A severe, fast-moving curve can squeeze lungs, pinch nerves, or cause extreme imbalance. For those rare cases, surgery may indeed bring relief and stability. But the first-line label, meaning fusion should be the default or automatic next step, does not fit with the evidence we have. Why complication reports vary so wildly? You might wonder how one study can call complication rate 0 while another claims almost 9 out of 10. Several factors drive this spread. Study length. Short studies miss late problems like broken rods or joint wear. Definition of complication. Some authors list only big disasters. Others count small issues like mild infections or loose screws. Curve type. Kids with neuromuscular or congenital curves usually face more complications than those with AIS, yet some papers combine all types. Surgeon skill and hospital resources. Top centers with strict infection control and high experience may see fewer issues than small hospitals. Understanding these differences helps families ask sharper questions when doctors quote success rates. The invisible costs: money, time, and peace of mind. Fusion's price tag stretches far beyond the hospital bill. Recovery can run 6 to 12 months, limiting school, sports, and social life. Parents may miss work to help with daily tasks. Insurance may cover surgery, but not extra rehab sessions or travel to follow-up appointments. In countries without universal health care, out-of-pocket expenses can climb into tens of thousands of dollars. Emotional costs are real too. Teens carry heavy worries. Will my hardware break? Can I still try out for soccer? Will people stare at my scar? These silent burdens rarely show up in medical charts, yet psychologists know they can affect mood, sleep, and even school grades. What high-quality proof would look like? To settle the debate once and for all, researchers would need to recruit a large group of teens with similar curve sizes, ages, and growth potential. Randomly assign half to fusion and half to modern, non-surgical programs, like reflexive response rehab, core strengthening, and genetic-based risk testing. Track them for at least 10 to 20 years, or until full growth and well into adulthood. Measure not just curve size, but also lung function, back pain, sports participation, mental health, and quality of life. Report every complication, big or small, early or late. Only such a rigorous study could prove whether fusion is clearly superior, clearly inferior, or roughly equal to non-surgical care. Until then, the door remains wide open for families to choose the path that feels safest and most sensible. Bridging the evidence gap with modern non-surgical care. Critics sometimes argue that kids need fusion because bracing alone is uncomfortable and unreliable. That view is outdated. Today's non-surgical toolbox is much larger. Reflexive response rehabilitation. Brain-based exercises train posture control pathways, helping the spine self-correct during everyday movement. ScoliSMART Activity Suit. A light, flexible garment that guides the torso into better alignment while walking, running, or playing. Genetic and metabolic testing. Identifies risk factors, like low serotonin or certain gene variants, linked to faster curve growth, allowing early, targeted therapy. Nutrient and hormone balancing. Supports bone strength and soft tissue health, which can slow or stop progression. Small curve camps and boot camps. Short, intensive programs that jumpstart neuromuscular learning and give teens a fun, peer-supported environment. These innovations tackle the causes of curve progression instead of locking bones into place. Many are low risk and can be started early before curves reach surgical size. When used consistently, they may reduce the need for fusion or delay it until all growth is complete, lowering complication odds. Honest, open talk, the best medicine. Because no treatment is perfect, an honest, objective, and open conversation about cost versus benefit is the safest compass. Families should feel free to ask surgeons, what is the longest study proving fusion helps teenagers live better or longer than staying natural? How many of your own fusion patients needed a second or third surgery? What is the plan if blood loss, infection, or hardware failure happens? What modern non-surgical programs could my child try first? A skilled, caring surgeon will welcome these questions. If answers are vague, rushed, or dismissive, it may be wise to seek a second opinion. Bringing it all together. No long-term, prospective, controlled studies have proven that fusion beats natural history for AIS. Complication rates are highly variable, sometimes alarmingly high, and late problems are underreported. Living with a curve often causes fewer limits than people fear, especially for angles under 80 degrees. Modern non-surgical care is no longer just a brace, but a wide range of science-based options that empower teens and protect the growing spine. Every decision should focus on the whole person, weighing medical facts, daily goals, and emotional well-being. A patient story to end with hope. Jasmine was 14 when her 55-degree thoracic curve brought her to an orthopedic clinic. The surgeon urged fusion sooner rather than later. Jasmine loved dance and worried a stiff back would end her passion. Her parents found a center offering reflexive response rehab and genetic testing. The tests showed high histamine and low serotonin, markers linked to faster curve growth. Jasmine began targeted nutrient therapy, twice daily posture exercises, and wore a ScoliSMART Activity Suit during practice. 3 years later, her curve measures 48 degrees, her lung tests are normal, and she made captain of the dance team. Fusion remains an option, but it is now a choice, not an emergency. Final thoughts. Fusion might someday earn top-tier evidence as a first-line answer for AIS, but today that badge does not exist. Instead, families stand at a fork in the road. One path is well-traveled yet unproven and carries real, sometimes hidden risks. The other path, robust, proactive, non-surgical care, continues to expand with modern science, carries fewer dangers, and keeps the door open for surgery later if it truly becomes necessary. Armed with the facts from Westrick and Ward and Weiss and Goodall, you can walk this fork with calm confidence, knowing that pausing to explore every option is not reckless, it is responsible. Your child's spine, health, and dreams deserve nothing less.